around the world, artificial urinary sphincter, over 10,000 a year are implanted in the world. Most of them, it is for men incontinence. And for example, in France, each year you have 1,200 artificial urinary sphincter which are implanted. And for the women, only 3 countries around the world are using this device to treat severe incontinence in women. You have some are used in the US, but it is not FDA approved, and it's only for the young girl with congenital abnormality. In Germany, they are using 100 a year, and in France, you see, from one year to the other, it's around 300 that we are implanting. In France, it is reimbursed by the Social Security. And sometimes it's the problem with the artificial urinary sphincter that it's not taken in charge by the health authority. So you know the device. There are 3 elements. It's in silicone. You have the cuff, which is in the woman implanted around the bladder neck. You have the pump, which is in the woman placed in the major labia. And you have the balloon, which regulates the pressure in the system and which is placed in the around beside the bladder in the retropubic space. So the position in the women around the cuff around the bladder neck, the pump in the major labia. And when you want to open the system is full of water with the radio-opaque liquid. So the patient catch the pump through the skin of the major labia, and you press on the pump, and then the liquid which was in the cuff is going to the balloon, and then that means that you have create a bigger pressure in the balloon, and then the water come back in 2 to 3 minutes in the cuff to gain again the continence. So the stress urinary incontinence is sometimes in the women can be due to urethral sphincter deficiency, and that is the indication of the artificial sphincter. It can be idiopathic, it can be urogenic, or in some congenital abnormality, and also in traumatic lesion of the sphincter. So in those patients, you have you can have a positive cough stress test, but the Bonnet-Marshall test or the TVT test is negative, of course. Otherwise, there would be an indication for a TVT, of course. And in this situation, so it's severe incontinence. You have some alternatives, but most of them are palliative. Bulking agent injection, balloons sometimes can be used, or continent or urinary diversion, or indwelling catheters or pads. You have some contraindication for the sphincter when the lady cannot activate the pump, or when she has mental deficiency or impaired mobility. Some contraindications are relatives. Radiotherapy, urinary infection, you have to treat reflux also, or the detrusor overactivity when you have mixed incontinence. Artificial urinary sphincter has been described, and when the patient wants to have pregnancy, it's possible. And if you have an hypotonic bladder and a chronic retention, you can combine the artificial urinary sphincter with chronic intermittent catheter. So the classical approach is open, suprapubic. The vaginal approach was tested but no more used because of the high risk of infection. And the laparoscopic approach developed from the year of 2005. Here on this slide you have the different steps for the procedure in laparoscopy, and the critical one is the dissection between the vagina and the bladder neck. This is already the case by the open approach. This is the critical step because you must avoid any injury of the vagina and any injury of the bladder. So the patient is in supine position, legs on the supports, to have free access to the vagina, because you will place your hand in the vagina. You will see. So there is a Foley catheter, and the arms are parallel to the body, like this, and the patient is fixed with adhesive sheet. So you use 4 trocar. The surgeon is on the left side. He used a lateral one here in the iliac fossa and a trocar which is in the just in the middle between the umbilicus and the pubic bone. And the assistant is using another one in the right iliac fossa and is holding the optics through the trocar, which is placed in the umbilicus. So here again, the preperitoneal space have been insufflated with a Veress needle, and you can see the Veress needle there. In this patient, she had previous surgery by a birch colposuspension some years ago, and it is why you have some scarring tissue that you can see. It's different from the video that we presented just before. So you replace the Veress needle by the first trocar, which is on the middle line, and then with this trocar, when you have such scarring tissue like this, you can progress to create the space by using the scissors to incise the scarring tissue. So when this space is enlarged, you notice that you have on the left side the bipolar grasper, on the trocar of the middle the monopolar scissors, and the assistant is using a grasper from the right. Then you progress to reach the pubic bone to enter the space which is anterior to the bladder to reach the bladder neck, because we will have to dissect the bladder neck to place the cuff. Again, this was a specific patient because she had scarring tissue. Then when the anterior face of the bladder is free, the surgeon is placing the left hand in the vagina and is indicating the cul-de-sac of the vagina. Here it is the left cul-de-sac. And with his right hand, with the scissors, you see, you make a dissection close to the vagina. You must see the white aspect of the vagina. There are some fat around the vagina. And when you reach the vagina, you progress medially under the bladder neck, and you progressively start the dissection, and you do the same on the right. But as you can notice, with the scissors in the midline port, it's not possible to have a good direction to pass under the bladder neck. So you will see we use a specific trick which has been developed by Eric Mandron again. And the trick is to perform a small incision, suprapubic incision on the side, and to introduce a classical scissors through the abdominal wall directly without doing any opening. And with these scissors, used by the surgeon and with the hand of the surgeon inside, you have a better orientation of the instrument to pass under the bladder neck. And so you have the feeling, by using the scissors, you have the feeling of your hand in the vagina, and you stick to the vagina plane to progressively pass under the bladder neck. You can check where the bladder neck is by moving the balloon of the catheter. In this movie, that was a trick that I don't use anymore, but I thought that it was maybe a good thing to lift up the urethra and the bladder neck by using this kind of Babcock grasper. But afterwards, it's when you are used to the procedure, the feeling of the scissors is sufficient on your finger, and you don't need to lift up like this. It's possible to use it, but then you have to place a larger port on the midline, because for this grasper it's a 12mm port that you need. And then progressively you reach the opposite side. There is always some tissue that you need to incise, and sometimes you don't know if it is the bladder, you don't know And it's why when you completed the passage, you have to check by injecting some glue in the bladder that you have no bladder injury. When you remove your hand from the vagina, you check that you have no blood on the gloves, which would be that you have maybe an injury of the vagina. So you check those two organs to be sure that they are they have not been injured. So the scissors pass through, so you replace it by a dissector. So you do the same way, you go through the same way with the dissector. And the dissector is also introduced by the same lateral incision. This incision will be used for placing the pump in the labia, so it's a necessary incision. It's not a supplementary incision. And then you will place the device to measure the circumferences of the bladder neck. This classical device that maybe you know, if you use artificial urine sphincter in men, it's the same. So that you will able to decide which size of cuff you will use. So you pull a little bit on the device, not too much, and then you reduce the size, you increase the size of half a centimeter. So here it's 6.5, you see, and we choose a 7 centimeter cuff. In the women, the cuff are larger than in the men. Huh? It's more around 6 centimeter in the women. In the men, it's more 4 centimeter. Then by the little suprapubic incision, you can introduce the cuff. Some guys, they introduce the cuff through the trocar, but I'm always afraid that you create an injury of the cuff by introducing through a trocar. You never know what can happen. So you remove the device to measure, and you replace it by the cuff, which will be followed the same way. You see, there are very few bleeding because of the pressure. That's the advantage of the laparoscopy. In the open procedure, sometimes you have vein in the pelvis in this woman, and you can have bleeding, but there with the pressure, you have the bleeding is limited. There I was checking if I have no catching the bladder posterior aspect of the bladder neck, but is the grasper. Okay, and so the cuff is progressively passing behind. So you have to connect the cuff on itself by placing the tube in the little hole there. So the tube is in the hole, and then it just connect the device on this little button there. So that means that the cuff is connected now. So the tube will be getting out by the suprapubic incision, and you introduce then the balloon by the same way. The balloon is empty when you introduce it, and then you fill it with 22 cc of water, which could be mixed with radio opaque liquid, so that when you will perform X-ray, you can see if the sphincter is in a good way. See the balloon, and it will be let like here in the retropubic space. You do not move because you are in a preperitoneal approach. If you can do it by transperitoneal approach too. Then you can fix the bladder to the bladder wall so that the balloon remains in a good position. So So you don't place any drain, you remove the trocar, by the suprapubic incision, you create the space for the pump in the major labia using dilators, and then you connect the tube like you do in the man, so that the device can be in function. You close the incision, you let it follow a catheter for 2 days, and you deactivate the device for a mean of 4 to 6 weeks. So in the recommendation in France, for example, we use the sphincter in severe urinary incontinence and when you have intrinsic sphincter deficiency. In the other countries, sometimes in the EAU also, it is recommended for recurrence, stress or mixed incontinence with limited bladder neck mobility. Here are some of the big study on the results from the artificial urinary sphincter in women. It's the French publication are the most numerous. This is the one from my colleague from Nîmes. You see more than 340 patients with very good results, success, and a follow-up of in this study for nearly 10 years. That's the other. So we present our laparoscopic IVS experience that I will pass rapidly. You see those women have been operated before with a lot of procedure. The mean operative time you see is 150 minutes. It's quicker when you do only a revision, when you change the device, when you have a hole in the cuff or hole in the balloon, you can change the device and it's more easy to do because you just follow the tubes and you change the balloon and the cuff. So you have some complication, some bladder injury. You can repair it directly. What is important is to check, in fact, to see that there is an injury, and then you can do a suture. It could be more troublesome if you have a vaginal injury which is not recognized, because sometimes you can have like this. It was not recognized, and you should explant the patient. If you can see the vaginal injury during the operation, I will not implant the device. You have to postpone the implantation. So, but the results are quite good, and those who are not completely cured, it means because they are mixed incontinence most of the time. So here are the three main data about laparoscopic implantation of the sphincter. Eric Mandon has published one data with 25 patients. Another publication from our colleagues in Paris, and our publication, 26 patients. And you can notice the complication more or less the same. There are not so much difference, and the results are relatively good. So this is an approach, a particular way to do laparoscopy, but you need to use this device in your armamentory to treat the stress urinary incontinence. And in France, it is considered to be the gold standard treatment for recurrent severe stress urinary incontinence in women, or those women who have no urethral mobility and who are not candidate for the suburethral tape. Thank you very much. If you have some question,